I think we can start. Hi everyone, again. My name is Nazim Gashi, and I will be sharing this session on water and sanitation. Welcome to the International Conference on Children and Their Families using the multiple indicator cluster surveys. Together with me is my co-chair, Eva Quintana, statistics specialist within the MIX program. Before I introduce our speakers, a few words of housekeeping. This session will be recorded and hosted on the UNICEF Mix website and YouTube channel as well, as on the BPI YouTube channel and embedded on the BPI website after the event. By attending, you're consent to be part of this recording. Please ensure that you have added your name rather than being listed as a guest, as the team will be monitoring attendees, and we will also need to know who is asking our speakers questions. You will be able to ask questions via Teams question and answer function on the top of your screen. And I'm kindly asking all participants to write down their questions and not to raise their hands. So please write all your questions in the Q&A function. And if you have multiple questions, please write them one by one in different messages, so not all of them listed in one message. Due to time constraints, we may not be able to answer every questions, but please be free to get in touch with speakers after the session to continue the conversation. Please note that the chat function is not available to attendees, so please use the Q&A function. And last, please be careful and respectful. All events at this conference are being monitored, and we reserve the right to remove attendees whose comments are deemed offensive and derogatory. In this session, we have 3 presentations. Each of them will last exactly 50 minutes sharp, and all the 3 presentations, and after all these 3 presentations, we will continue with the questions. Now I give the floor to Vanesa from Argentina, University of CEMA, and she's going to present on the economic impact of access to improved water and sanitation on diarrhea reduction in early childhood in Argentina. Vanesa, over to you.
Okay, thank you, Nazim. I'm going to share my screen now. Okay. Okay, thank you. Good afternoon, everyone. My name is Vanesa from Argentina, from UCEMA University. Today, I'll be presenting our study on the economic impact of access to improved water and sanitation on diarrhea reduction in early childhood in Argentina. This is a work. This is a work that we do with Matilde Karczmarczyk from Argentina too. Okay, let's begin with the motivation behind our study. There is empirical evidence linking diarrhea to the lack of access to adequate water and sanitation services. Children under 5 and the elderly are the most affected groups. Mortality from diarrhea is the 3rd leading cause of mortality in early childhood globally and in Argentina. And given this relevance, we aim to ask these 2 answers. First of all, what are the health benefits of improvements in water and sanitation? And then what are the monetary benefits of human lives saved due to the improvements in water and sanitation? Our focus is on early childhood. Regarding the methodology, we follow these steps. First, we calculate the attributable fraction of diarrhea to the lack of safe water and sanitation services in the population. For doing this, we use this formula that is a very common formula in this kind of studies. Then we apply this attributable fraction to the number of death or morbidity cases from these diseases. For doing this, we used the concept of disability adjusted life years, that is, And finally, we valued this death and morbidity in terms of money. We multiply the MAD by a present value factor in order to estimate the economic benefits. Okay, our study used data from mixed survey that was conducted in Argentina between 2019 and 2020. And this is the main innovation of this study, the use of this survey. And this survey includes more than 30,000 households of urban areas with a response rate of 84.5%, and 7.1% of the data set are children under 5. So we use these mixed questions for our study regarding conditions of drinking water, sources of water for other purposes, and use of sanitation facilities. We use them to access people to improved or unimproved water and sanitation sources. What is an improved water source? Is the source that distributes water safely and free of contaminants. An improved sanitation facility is that safely separates human waste from human contact. So this classification allowed us to analyze the population's exposure to different levels of risk. We group the population into different exposure scenarios. Those scenarios are those defined by the global burden of disease. There are 7 scenarios. For example, scenario number 1 is the ideal situation where there is no transmissions of diarrhea through water or sanitation. And scenario 2 is the one that reflects the situation of developed countries. As you move from scenario 1 to scenario 7, the probability of getting sick increases. 98.5% of total population has access to improved water. 73.3% of population has access to improved sanitation, and 72.5% has access to both improved water and improved sanitation. The maps here, this is Argentina, show that coverage is not only lower in the case of improved sanitation, this is the map that reflects this situation, but also that the distribution of the coverage is unequal across the different regions. For example, the Patagonia, that is the region in the south of our country, has 95% of coverage, while the NIA, that is the northeast area of our country, has only 61% of coverage. When we looked at income levels, we found that higher income is associated with better access to improved water and sanitation services. You can see this just looking at the blue bars. For example, in the first quintile, 34% of total population has access to improved water and sanitation services, while in the last quintile, 99% of total population has access to improved facilities. This pattern is verified in both, in total population and in children under 5. So I'm going I'm not going to stop in this slide just to stick to our schedule. We can come back later if it is necessary, but I want to show you the DALYs formula that we use to calculate the DALYs avoided. And to calculate the DALYs, we start with the number of deaths due to the diarrhea and the number of disease cases, that is the morbidity, including both those that require hospitalization and those that did not. That is just the notification of the diarrhea. To calculate the present value of the benefits from diarrhea reduction, we use this formula. We convert DALYs avoided into money by multiplying them by income. We use for doing this the minimum living wage, because the group affected is the group in the lower part of the distribution of income. So all our calculations are a limit, a bound. So let's move to the results. Here, moving total population to the ideal scenario, it is scenario number 1, could prevent 91% of total deaths, 94% of total hospitalizations, and 91% of notifications. The same happens in the case of children under 5, and the percentage is 77% in the case of moving the population to scenario 2. So these findings highlight the significant health benefits in our country to improve water and sanitation, especially in the early childhood. Regarding the economic benefits, we found that the benefit range from $126.9 million to $148.9 million, and that these represent more or less 1/3 of total benefits. Okay, and to conclude, our study makes several contributions. First of all, it is the first study that focuses specifically on childhood in Argentina that uses mixed data. We could combine different sources of information. We integrate data from MIX, from UN, and from the Ministry of Health of Argentina. Here you have the estimated benefit avoided death and mobility in terms of DALYs. But something that I would like to mention is that these estimated costs are below the cost of investment required to improve water and sanitation access, that are estimated at $10,000 million, more or less. Apart from that, these benefits are a lower bound because additional benefits such as improved nutrition and reduced caregiving time for sick children, for example, have to also to be considered in this cost. Okay, and thank you. I think that I'm okay with the time.
Oh, you made my life much easier. You ended 2-3 minutes before your time. Thank you very much, Vanesa. We will, if anyone has any question, you can write them down. And after we finish with the other 2 presentations, we can raise the questions for Vanesa. Thank you very much for this excellent work, Vanesa. And now I pass the floor to Rebecca Harding from Walter and Eliza Hall Institute of Medical Research in Australia. and she's going to present about epidemiology of menstrual-related absenteeism in 44 low and middle income countries. So Rebecca, over to you.
Thank you very much, Nazim. Yes, and good evening. I'm speaking to you from Melbourne in Australia.
Sorry, Rebecca, can you put it in slideshow? So we are seeing the slides, but not. Yes, perfect. Thank you. Yeah, you can continue. Thank you.
That's all right. 1 second. So just saying, I'm presenting from Melbourne, Australia here this evening. So thank you very much to be able to present our work, which I'm presenting on behalf of all of my collaborators, both here in Australia and overseas. So I wanted to start by defining menstrual health. It's a broad term encompassing a state of complete physical, mental, and social well-being, particularly in relation to the menstrual cycle. So this includes having access to appropriate information and education surrounding the menstrual cycle, as well as a lack of misinformation, which is a common problem in some cultures. The ability to effectively manage menstrual hygiene through access to appropriate menstrual materials and associated disposal pathways, as well as access to appropriate water and sanitation facilities to allow women to wash and change in privacy. Having a respectful environment free of stigma and also free of any teasing or harassing by peers, as well as an environment free from exclusions or restrictions that are enforced by society in relation to the menstrual cycle. This could also include restrictions towards food preparation or interactions with men, as well as potential exclusions from religious activities. Lastly, menstrual health involves access to timely diagnosis and treatment of menstrual disorders. While there are a broad range of consequences that can result from poor menstrual health, today I'll be focusing on one, which is related to menstrual-related absenteeism from work, school, or social activities. Absenteeism has a potential to contribute negatively towards women's financial situations and their educational developments and achievements, as well as their social lives and relationships. As menstrual-related absenteeism is only experienced by women, it also contributes and exacerbates gender inequality, posing a serious barrier to achieving Sustainable Development Goal 5, where we hope to achieve gender equality and empower all women and girls. Several studies have looked into the reasons for menstrual-related absenteeism from school and adolescence in low and middle income countries, but we wanted to use this outcome as a proxy for studying menstrual health more broadly. And this is because it is measured in several national and demographic surveys. So these sources of data have large sample sizes and cover a broad range of topics, allowing us to gain a more holistic understanding of menstrual health. So in this study, we really wanted to look at what factors are associated with absenteeism from work, school, or social activities during menstruation, in order to better understand factors that contribute to menstrual health more broadly. We aim to estimate the association of demographic and environmental factors with absenteeism in order to identify key targets and priorities for future research and interventions. In order to do this, we use data from the nationally representative mixed surveys, where in this study in particular, we use data from the household and women's questionnaires. So for us, our study outcome was menstrual-related absenteeism, which was added in the 6th round of the mixed surveys in 2017. It asked women who menstruated in the last 12 months if there were any social activities, school, or work days missed due to their last menstruation, and the woman could either answer yes, no, don't know, or no such activity. So we found that there were 47 mixed surveys from 44 countries that measured our outcome of interest. So this led us to a sample size of 673,380 women from almost 500,000 households who had information on our menstrual-related absenteeism outcome. And we note that the only country with multiple surveys here was Pakistan, which had 4 surveys, each for a different province. Next, I want to briefly go over the factors that we thought might influence menstrual-related absenteeism and where our chosen independent variables fit into these factors. First off, we would expect that improving menstrual hygiene management through the use of menstrual products or access to appropriate wash facilities would lead to reductions in menstrual-related absenteeism. So in our study, we include the use of menstrual products and the availability of a private place to wash at home during menstruation as indicators for menstrual hygiene management. We just note here that the mixed round 6 didn't measure the availability of private wash facilities outside the home, but we think this could have been a better indicator for wash contributing to absenteeism. Next, we would expect that reducing menstrual symptoms would also reduce menstrual-related absenteeism. So we've included the use of a contraceptive as an independent variable, as well as contraceptive methods that I won't touch on today. But we think these might help particularly menstrual-related symptoms like heavy menstrual bleeding and pain. Other social factors such as stigma and cultural practices are also expected to be important, as well as menstrual education. However, these factors weren't captured well in the mixed surveys, and so we haven't included them in our analyses. We did, however, include some demographic factors, so we included age and household wealth index. We predicted that absenteeism would be higher in younger women who generally have less menstrual education and may also experience worse menstrual symptoms. And we also predict absenteeism to decrease with increasing wealth. Moving on to our methods, we first restricted our sample to women who answered either yes or no to the outcome variable and relevant independent variables. So then for each exposure and outcome association, the prevalence of menstrual-related absenteeism was compared across groups to calculate the prevalence ratios using log binomial models, both before adjustment and after adjusting for relevant confounders, which we identified using a directed acyclic graph. We use random effects meta-analyses to pool our estimates both by geographical region and across all surveys. So this map shows the prevalence of menstrual-related absenteeism by survey country. So the darker colours here represent more menstrual-related absenteeism. The pooled prevalence by region was 6.8 in Europe and Central Asia, up to 19.7 in South Asia, with an overall pooled prevalence of 15%. This to us demonstrates how common menstrual-related absenteeism is across the globe. Moving on to our prevalence ratios. We analysed age using a 5-year age group, with 15 to 19-year-olds being our reference group. The plot here shows the prevalence of menstrual-related absenteeism, pooled by region, shown in the different colours, and age group along the x-axis, with the black line showing the overall pooled prevalences across all surveys. This graph allows us to make comparisons between all age groups, rather than just comparing to 15 to 19-year-olds. We see here that absenteeism generally decreases with age until about the age of 25, and it remains relatively stable until age 45, where absenteeism ticks up again. We suspect this aligns with what we know about how there are 2 periods in a woman's life where biology influences menstruation symptoms or bleeding, namely the onset when they're young, and at the end due to the onset then of perimenopause and associated changes to the menstrual cycle. Moving on to wealth. Mixed wealth scores capturing the long-term wealth of a household were used to construct wealth quintiles, which we then used in our analysis, with quintile 1 representing poorest households and quintile 5 the richest. This plot is similar to the last one and shows the prevalence of menstrual-related absenteeism pooled by region and wealth quintile. What we can see here is that the pooled prevalence of menstrual-related absenteeism is fairly stable across wealth quintiles, with the exception of South Asia in the green at the top there, where absenteeism is slightly less common in the higher wealth quintiles. Moving on to the use of menstrual products. So the mixed surveys asked women if they used any materials such as pads, tampons or cloth during their last period. So with an overall pooled prevalence of 94.9% of women who were using menstrual materials, which ranged from 87.2 in South Asia to 98% in Europe and Central Asia. So this forest plot here shows our prevalence ratios for the use of menstrual materials, with countries again ordered by region. So the diamonds represent the pooled prevalence ratios by region, while the vertical line represents a prevalence ratio of 1 or no association between the use of menstrual products and menstrual-related absenteeism. So prevalence ratios to the left of this line indicate less absenteeism in women using menstrual materials, while estimates to the right indicate less absenteeism in women not using menstrual materials. So what we can see here is the majority of the prevalence ratios are close to the null line, with wide confidence intervals crossing the null. This is also true of the region pooled prevalence for East Asia and the Pacific, Eastern and Southern Africa, and Europe and Central Asia. Therefore, we don't see any clear association between the use of menstrual products and absenteeism. Similar results were observed across the remaining regions in Latin America and the Caribbean, Middle East and North Africa, South Asia, West and Central Africa, as well as in the overall pooled effect in the Black Diamond. The 7th round of mix that began last year changed the menstrual products indicator to instead ask women if they have menstrual materials to manage their hygiene, and we think this could better capture some unmet need. So we're looking forward to those results when they do come out. Moving on to wash. The mix surveys ask women if they're able to wash and change in privacy while at home during their last menstrual period. The pooled prevalence of women and girls with a private place to wash and change at home during menstruation ranged from 78.9% in Middle East and North Africa to 97.3% in Europe and Central Asia, with the overall pooled prevalence of 91.6%. Again, here we see another forest plot, with estimates to the left of the null line indicating absenteeism in women with private wash facilities at home, and estimates to the right indicating more absenteeism in the women. We can see that most countries having a private place to wash at home was associated with the higher prevalence of menstrual-related absenteeism, and this is reflected in the pooled prevalence for East Asia and the Pacific and Eastern and Southern Africa. However, the opposite trend was observed in Europe and Central Asia, where the results indicate a lower prevalence of menstrual-related absenteeism with having a private place to wash at home. Across the remaining regions of Latin America and the Caribbean, Middle East and North Africa, South Asia, and West and Central Africa, the private wash facilities at home were generally associated with the higher prevalence of menstrual-related absenteeism, with the overall pooled estimate indicating a 30% increase in absenteeism in those with private wash facilities at home. Lastly, we looked at contraceptive use, comparing menstrual-related absenteeism in women who used any method of contraceptives to those who used no contraceptives. The region pooled population of women and girls using any method of contraceptive varied from 24.1% in West and Central Africa to 60.2% in the Middle East and North Africa, with an overall pooled prevalence of 38.6% of women using any method of contraceptives. Estimates to the left of the null line here indicate less absenteeism with women using contraceptives, while estimates to the right indicate less absenteeism and women not using them. So we can see here that in almost all countries in the regions of East Asia and the Pacific, Eastern and Southern Africa and Europe and Central Asia, the use of contraceptives was associated with the lower prevalence of menstrual-related absenteeism. And the same trend was seen in the remaining regions of Latin America and the Caribbean, Middle East, North Africa, and West and Central Africa and South Asia, with the overall pooled effect indicating a 14% reduction in absenteeism in women using contraceptive methods compared to those with no contraceptives. So to summarise, our results, we found that adolescents and young women are at higher risk of menstrual-related absenteeism, but with no clear association observed between wealth quintiles or menstrual materials and menstrual-related absenteeism. Women with private wash facilities at home were at higher risk of menstrual-related absenteeism, suggesting poor out-of-home wash facilities, while contraceptive use was protective against menstrual-related absenteeism. We think future national surveys could include more comprehensive menstrual modules to inform future research and global health priorities. And just on that, I would recommend people who are interested more in this, there's another session in this in session 16 tomorrow morning, which I think could also gain some valuable insight. Thank you.
Wow, I really have a good crew. Everyone is keeping on track with the time. So thank you very much, Rebecca, for this great work. really interesting, and I'm really interested in learning even more. And thank you. Now I'll pass the floor to the last presentation. But before doing that, I'm kindly reminding everyone that you can start writing your questions under the Q&A function. So if you have anything, please write it down there. And after the last presentation, we will open for Q&A. So now I will give the floor to Robert Bain, our colleague, UNICEF colleague from the Regional Office of Middle East and North Africa, who is going to present inequalities in drinking water services levels in low and middle income countries, insight from the mixed surveys from 2014-2023. Thank you, and over to you, Rob.
Thank you, Nazim. Let me just pull up the slides.
And if you can, your camera as well.
Okay.
Perfect.
Right. Well, thank you very much, and good afternoon, everybody, and good morning to those of you a bit further east. I think, Rebecca, you're probably one of the latest, given your time zone, so thanks for joining us. I think this study is looking at inequalities in drinking water service levels, and it links a bit to some of the work that Vanesa's doing. So you'll hear some of the same terms around improved sources, as well as sort of safely managed. My co-authors, Tom Slaymaker and Richard Johnston, Rick Johnston, are both online, so thanks very much for joining. And I think it's also important for me to acknowledge the great support I've had from a wider range of colleagues and collaborators in terms of influencing the methods. So let me just jump to the next slide. So the context of this is for SDG monitoring for 6.11, which is a target for universal access to safe drinking water. And we have a set of definitions that are used at the global level, and I've shown those on the left-hand side here. I think for many of you this will be familiar, but for those of you not from the WASH sector, this might be the first time you've heard these, or there might be some points which are new. What you see is that the sort of top level of service called safely managed, which is a new and very higher level of service, which was part of the SDGs. Before that, we were monitoring just the type of water source. So a safely managed source, there's an illustration on the right-hand side here which describes that. So it's a water source which is of an improved type, which is available when needed, it's accessible on premises, and it's free from contamination. And these are all bits of information that have been collected in mix in a good number of countries in the 6th and 7th rounds. What I will do in the next slides is show you the sort of MDG indicator for improved as well as safely managed, and then the elements of safely managed, so the quality, the accessibility, and the availability. And we'll be exploring the inequalities by wealth and residence. So the objectives were to assess the inequality in safely managed drinking water and its subcomponents by residence and wealth quintile. And the way we approached this was to take all of the mixed surveys that are national, that included water quality testing, and calculate improved drinking water, so the MDG indicator, as well as safely managed drinking water for population subgroups in 38 countries. So almost as many as there were for menstrual hygiene. It was almost as popular a topic for countries to include. And then we calculate inequalities in access by wealth and residence. And then there's some regression modeling to look at risk factors. We ended up adopting a modified Poisson regression model, which allows you to report on risk ratios. It's quite similar to a logit model or similar, but it is a slightly different kind of framework to the meta-analysis that Rebecca showed. I won't go into any details on that in this presentation, but there's a paper that I can point you to with more information. Okay, so what data sets do we use? So it's all mixed with water quality testing, and this is household survey teams collecting samples of drinking water, 100 millilitres, and testing them for E. coli, which is an indicator of fecal contamination. Typically in mix, it's a subsample of households. So in a cluster of 25 households that we usually have in a survey, we tend to pick randomly 5 of those for the water quality module, partly because water quality is relatively similar within a cluster, but also to make the fieldwork feasible. I'm only including national data sets, so I haven't included the subnational surveys in Pakistan and elsewhere in this analysis. And we've also excluded a couple of surveys that used either a different test method or where data wasn't available. We also excluded the latest survey in Tunisia, partly because there was a low response rate compared to the previous one. And that was because the teams had to revisit households to collect water quality samples due to a kind of a logistical hiccup. Okay, so we had 38 countries, 500,000 roughly households interviewed, and then around 70,000 with information on water quality and then able to calculate safely managed drinking water. This analysis builds on an earlier study from a few years ago, which looked primarily at water quality, but also looked at safely managed, but not in the not with a specific focus on inequalities. So just as a kind of overview, the levels of improved drinking water, this is the MDG indicator, were relatively high in a large number of countries. You'll see that there are some that drop down to under 50%, like Madagascar, and others that are more in the kind of 60–70% of the population. So still very large proportions of the population without an improved drinking water source. But there's a dramatic difference between improved and safely managed across all of these countries, ranging from the low percentages to in sort of Sierra Leone, Central African Republic, Chad, Nigeria, through to higher levels in Palestine, obviously pre-conflict. And if we sort of pull those estimates, you'd get roughly 88% for improved, and then around a third with safely managed drinking water services across those countries. If we start to dig into inequalities by residence and by wealth, here you can see in the middle we've got residence, where we've got rural in a lighter green and urban in a darker green. And you can see there are quite big differences in some countries, in general with safely managed being higher as we'd expect in urban. In some countries it's quite close. I think one of the interesting ones was Bangladesh, where we see that there's an overlapping confidence interval, but the quality, well, so safely managed has been found to be generally slightly better in rural areas, because you have issues with availability of drinking water in urban areas in particular. You're comparing sort of piped water supplies in large urban centres versus boreholes, which are primarily used in rural areas. So you see very different patterns, but overall quite a big difference between urban and rural. And similarly, or perhaps more dramatically, if we look at the richest 20% and the poorest 20%, you see bigger differences there. Of course, we're comparing smaller subgroups of the population, but you can see some big differences there. So in the next slide, this is a little bit overwhelming perhaps, and let me just run through what we're trying to show here. So on the x-axis, we've got wealth quintiles going from 1 to 5, so that's poorest to richest. And then each of these charts shows a different country or a different survey. The line at the top is improved, and then there are a series of lines in between, improved and safely managed, which is the dark blue at the bottom. And in between we have a sort of a full line for improved and accessible, a dashed line for improved and available, and then a dotted line for improved and no E. coli. I think if this ever goes into print, we'll need to work a little bit more on the graphic design. But I think what's quite startling here is the different patterns that you see across many countries. So I've already talked a little bit about Bangladesh. I think it's interesting to see, for example, in Dominican Republic, where you have most of the so improved is relatively high and relatively flat. Safely managed is a lot lower, driven by water quality, which is the dotted line there. Let me zoom in a bit. So you can see here that's the limiting factor for safely managed. If we look at another country, so for example, Guinea-Bissau, what we find is that there's a larger difference between the poorest and the richest when you look at improved than when you look at safely managed. And I think one of the sort of key messages that I'll come to is that you want to be monitoring the different levels in the service ladder when looking at inequalities, because there is a risk in just looking at safely managed. So let me jump to the next slide and the next one, where I had a couple of other countries that I wanted to highlight. So I think Nigeria is perhaps a more kind of classic type of inequality where all of, say, improved and it's the elements of safely managed all get better with wealth quintile. Kiribati is a country where you can see that the more usual patterns for improved, but when you look at available, it's much flatter. And Vietnam here is a bit like the Dominican Republic, where you have relatively high levels for improved, accessible, and available, but then quite a big drop when you consider water quality. Okay, so jumping to risk factors. So these are showing adjusted risk ratios for, in the first column, improved drinking water services, then accessible, available, and then free from contamination, and then safely managed in the last column there. And if we look at the socioeconomic characteristics, we can see here that there's quite big differences by wealth quintile, which matches what we've seen in those charts. I think it's important to see how the risk ratios sort of tend to increase as you go towards safely managed. So you're kind of compounding the risks of having water that's not accessible, available, or of high quality, which I think results in this larger risk ratio when we look at safely managed than when we look at the richest for improved relative to the poorest. Not much difference, or it's not statistically significant difference by sex of household head or education, but we do see quite a big difference for rural versus urban. And again, if you look at improved, there's a risk ratio of 0.94, whereas if you look at safely managed, it's 0.8. So a lot larger or more pronounced differences when you look at the higher levels of service. We also included quite a number of sanitation-related variables, and you can see here a similar story with improved sanitation. So it's associated with many of those models, particularly for improved and accessible, less so for water quality, which is perhaps surprising. But then for safely managed, there's quite a strong association there. And we tried to include a number of kind of cluster level variables as well as individual households, because the expectation is that sanitation it's the environment in which you live in that would influence so the quality of your drinking water. Okay, and then looking at the water supply type. So for this model, because we're looking at the water supply type and both improved and safely managed are by definition are improved sources, I've excluded unimproved sources from this model. And what we can see is that with a reference category of piped water, again, we see that as you go towards safely managed, your risk ratios get larger in general. You don't see that you see that for packaged water, but not for boreholes or tube wells, where it's not statistically significant. And I think there's some interesting patterns here in terms of, for example, rainwater is more likely to be accessible on premises, but it's much less likely to be free from contamination than piped water, for example. Okay, so in conclusion, we see some substantial differences between safely managed and improved, and that's something that's very well known. It's been reported by the JMP for a number of years, as well as some recent studies that have taken this data set, this mixed data set, and then sort of extrapolated that to low and middle income countries. I think that's well known and understood. But the mixed data really give us a sense of how big that difference is and how it varies. The degree of inequality depends a lot on the metrics and the service levels used, which underscores the importance of looking not only at the SDG safely managed, but also some of the lower rungs. And if we look at the relative risks in these models, what we see is that you can get quite different relative risks for safely managed and its elements, so the accessibility, availability, and quality, when you look at those compared to, say, improved water sources. And I think this might be quite interesting for Vanesa, so where you're building models, economic models, health models on the basis of improved, unimproved, versus maybe trying to include some elements of, say, accessibility or availability, where that data is available. And then in terms of further work, I think one thing that I'd really like to do is to make more use of inequality metrics, so concentration indices, risk differences, to summarize the information that you saw in those charts. There's also some important work to be done to look at the comparison of inequalities between household data from surveys and administrative data. And to look at inequalities within and away from home, as well as Nazim's favourite topic of mixed GIS and how we can start to use the data from countries that have water quality and GPS coordinates together. Thank you very much, and over to you, Nazim.
Thank you. Because you mentioned my name, I let you to have 1 more minute, so you did it in 60 minutes. And thank you very much for your presentation. So we had very good presenters, starting from the epidemiology of menstrual-related absenteeism in one side, and then 2 other researchers related more together, like from Vanesa in economic impact of access on improved water sanitation, on diarrhoea reduction, and then Rob's presentation in inequalities in drinking water service levels in low and middle income countries. So thank you very much all for your presentations. And maybe by talking a lot for the time, I scared people on making questions. I see only 1 question. And I'm gonna read it. So I see new comments. We have 12 minutes for question and answer. So please, if you have anything, you can write it down now, and we'll go one by one as they come. First question is for Rob. It's coming from John. So question for Rob and Bain. How confident are you in the usefulness of the measure of availability? The subjective precipitation of sufficient yes/no, particularly how it might be reflecting the same condition or not across different informants. In some data sets, we have been surprised. At how many informants report sufficiency. Maybe some informants' expectations are low to classify as sufficient. Sorry, I hope I read it completely because it's the first time that I'm reading. Rob, over to you if you can answer this.
I can have a go. Yes, I mean, it's a really good question. And there has been a lot of work in different contexts to try and understand sort of availability, intermittency, continuity of supply. there's some work that John, you might be familiar with, that looks at household experiences of water insecurity and tries to understand the different uses, and goes into a lot more granular information. I think there is some interest in exploring whether some of that could be incorporated in Mix through, for example, Mix Plus, so where you could have a bit more detail collected linked to your main survey. But in terms of the usefulness of people's subjective perception, I think that's sort of what household surveys are trying to get at. Now, if I think in the region that I sit in now, in the Middle East and North Africa, it's got some of the countries that have reported the greatest percentages of not sufficient. And I think it'd be interesting to point you to the Yemen mix recently, which had, unfortunately, didn't include water quality, so it's not part of the analysis that presented. But there's much lower levels there. But I think it's it's an ongoing discussion. You also have considerations of the season in which you're asking the availability questions and how that might influence the responses. But you are asking the respondent to make an assessment based on the last month and whether they've had sufficient drinking water. So there's a few things that they have to be digesting and reacting to. So what is sufficient, what is so that I think is something that's quite challenging. We did do, as the Mix team, in collaboration with the JMP, some field tests in Belize a number of years ago, and that informed the questions that were used in Mix 6. And what we found there is if you tried to ask questions that were perhaps a bit more objective, so if you asked about hours of supply or similar, you got data that were not that reliable. And part of the reason is you're asking someone to report on numbers of hours of supply in the last day or two, in the last 24 hours, but they're probably not trying to use water for all of those hours. So their ability to make that assessment was not not immediately straightforward. There have been loads of studies that have kind of tried to come up with indicators of availability. But I think it's, I don't know if I've sort of answered or partially answered your question. And I would also, direct you to speak to Tom Slaymaker and Rick Johnston, who are both online, who co-lead the JMP. So I know there've been some developments since I left that team. So you may want to reach out to them.
Thank you, Rob. I think you answered the question, but John, if there is something in addition, please write down again. We have a question for Rebecca coming from Tom Slaymaker. So Rebecca, nice presentation and interesting analysis of pool prevalence. How do you explain the apparent positive association between private place to wash and change and home and higher absenteeism from work, school, and social activities? Rebecca?
Yeah, thanks, Tom. Really interesting question. What I'm sort of going to propose and answer here is kind of a theory or a hypothesis that we sort of have, but I can't validate it with the data that's in the mix at the moment. So as you note, that the private place to wash at home was associated with this increased prevalence. So we kind of thought maybe this suggests that there's kind of suboptimal out-of-home wash or sanitation facilities, and so that perhaps there's higher absenteeism from work, school, or social activities because they feel more comfortable being at home and having that private place to wash. And so we sort of know that this is supported by previous literature, which has found that sanitation facilities in low and middle income schools are often, particularly in schools, are unacceptable for this menstrual management. And implementation of these sort of female-friendly toilets, so those that are clean, safer, accessible, and private, we suspect might improve menstrual health for women and girls, and therefore mean that they're less absent from school because they have those facilities. But again, this is we can't sort of look at this because there's no particular question we've seen in the mix that looks at what are those facilities like at school or work or other than being at home to kind of look into that. So more studies would help us better understand that, but I guess that's where our theory or hypothesis is on that at the moment.
Thank you, Rebecca. Tom, if you have anything in addition, please write again. We have another question for Rob and Rebecca as well. It's coming from Gudaro Landmedi. So for Robert, did you have a chance to assess the risk factors within each country region? Do you think that there is no specificity of risk factors for each country or region? The same question could also apply to Rebecca. Thanks. So first Rob and then Rebecca, if you can answer.
Thanks. So, yeah, I mean, it's an important question. I think these pooled risk ratios across all countries that decided to include water quality testing, it masks a lot of difference between different settings. What we did in the previous study, so the one that I included a screenshot of, was we had tables of the risk ratios as supplementary information. I have produced a chart for every country showing coefficient plots for every country, but the journal didn't want to go down that route. They preferred sort of summary tables, but certainly you see differences in the risk factors for water quality. I haven't done that analysis yet for safely managed drinking water, but undoubtedly looking at the patterns of inequalities in those charts, you would expect that the risk ratios would be quite different. One of the tricky things is that obviously your sample size is a bit limited if you have a subsample of sort of 3 to 5 households for water quality. So you might want, if you're going for country level models, to slightly reduce or restrict the number of variables or covariates that are included. So I was interested in the approach that Rebecca mentioned for covariate selection. I think you need to be getting fewer variables than I had in the sort of global or lower middle income countries model overall. It'd be nice to do some regional analysis. I think the patterns in a number of the mixed surveys in particular regions are relatively similar, at least when you look by wealth quintile. So you might see kind of more homogeneity in the risk ratios if you were to split things up by region, but you wouldn't lose as much by way of sample.
Thank you, Rob. Rebecca, do you have anything to add? And this is the
thanks,
last,
Rob.
and we are closing. Thank you.
Just on that, Rob, I'm very happy to talk to you about how we selected our covariates, so do feel free to reach out. Thank you for the question. We didn't necessarily assess the risk factors within each country or region specifically in the presentation today, but it is something that we could potentially do, but it's not something we've done at the moment. I do note that in all of our pooled analyses, there is actually quite high heterogeneity across all regions and overall. And so whether there's any specificity of these risk factors, I think to really answer that, you just have to look at country by country or region by region to really know that. But I do think it is, worth looking into if you're interested in a particular region or country to see kind of from there what public health interventions would work best, particularly for menstrual health in the area that you're working in. But unfortunately, I can't elaborate on any specifics at the moment.
Thank you. Thank you very much. So thank you to all the wonderful speakers for interesting presentations. Also, thank you to all the participants for engaging in discussion and for your important and interesting questions. Just a quick reminder that this event has been recorded and will be available via the mixed program and BPI meaning Bristol Poverty Institute website after the event. where you can watch it back and or share the link with friends and colleagues who may be interested in watching. You can, of course, also catch up with any of the conference sessions with you, which you may have missed. Now, with this, I'm going to close. I'm going to thank all of you for joining, and I will end this meeting, and the next session will start in 15 minutes. So please, I'm going to end this meeting, and if you are interested in following the next session, you have to rejoin again. Thank you very much and have a nice rest of the day. Bye-bye.